नमस्कार, हरे कृष्णा। आज मैं आप सबके साथ दोबारा हूँ in order to discuss one case which is an organophosphate poisoning. Now this poisoning is something which we are going to witness very commonly in northern part of this country, and this case has been a challenge for us, and through this compendium we are going to help you in understanding about how to manage the organophosphate poisoning, what are the challenges and what are your targets which you are supposed to have. And before I reach to this unfolding of the case, I would like to know first from you, Dr. Ankit, what this case was all about and what were the patient details to begin with.
Thank you. This is a young female. She is admitted with the complaint of intake of unknown substance, which we unfolded it. It was a organophosphorus poisoning.
So she was, I think she has taken chlorpyrifos, which is a organophosphate.
Yes.
So she has taken OP.
Yes. OP poisoning intake was there, and plus along with this, when she came, she was in altered sensorium. She was all cholinergic crisis was there.
Cholinergic crisis,
Yes.
cholinergic excess.
The excess was there. So with all this symptoms, she got intubated in our ICU, and along with this complaints, she is also we discovered she is 37-week pregnant also.
So they are two important. Yesterday also we had a discussion with respect to the patient with the pregnant status.
Yes.
And this was another case where the patient we were dealing with was pregnant, and pregnancy which got complicated by the poisoning, organophosphate poisoning. Okay. So this patient, Dr. Datta, I would like to know your view. If the patient is coming as a case of unknown poisoning, because to begin with, many of the time you may not be having an awareness that what kind of a poison the patient has taken. So what is your general approach in managing these cases for the poisoning?
General approach is to ask the attendants if they have anything to show.
Anything specifically which the patient has consumed?
Like a bottle of the poison, or if she has consumed some tablets, if they have got some sample. If it is not known, then we go on the clinical presentation of the patient.
So two important things which I have learned from you, Dr. Datta. One, history taking. More specific, the poison history is very important and relevant, which you have to take from the family and the best possible relative who is in the close vicinity of the patient, who actually know that what the patient has gone through. Most of the poisonings which we witness, they are basically suicidal or maybe accidental, right? And the second thing which you said, in case if I don't know the poison, then you're going to approach them on the basis of the syndrome or the constellation of signs and symptoms which your patient is having, and you identify what category of poison your patient is likely to be, right?
Yeah.
But having said so, Dr. Datta, so these are two important things. But what you do as far as a clinical management is concerned, the basic management, which you feel as an emergency resuscitation specialist, what do you think should be the initial line of management? Let's say the patient has taken some unknown poison and within 2 hours the patient is there with you.
Initial line of management, what we do in our setup is to do a gastric lavage.
Gastric lavage.
That is very important. We do a gastric lavage in normal saline, and we preserve the sample for further forensic examination.
So that is another important.
That is important part of the examination part, and then we see the ABC. Airway, breathing, circulation,
Excellent.
level of sensory.
So very good. So Dr. Ankit, Dr. Datta has said that the first and foremost, especially if the patient is coming in a window of 3 hours, 4 hours, where you don't actually expect that the poison is going to be absorbed, especially if the poison has taken orally. We're not talking about the poison which has been spilled over the skin. Like for example, the patients who have been exposed to the volatile, the agents, they are the situation. Now, as Dr. Datta has said that your patient is coming with something within 3 to 4.5 hours. So the first and foremost, you lavage them, right? So you put a nasogastric tube and you do a lavage. You basically give charcoal or maybe the saline or maybe the burnt toast. Multiple things has been advocated in the past or in the present literature. And simultaneously you take off the sample and send it for the toxicological analysis, because we need to know what is the nature of the poison. Do you do lavage in all the poisons, or do you think there is any contraindication as per your understanding?
Yes. in all the
You have to be loud, Ankit. Huh?
in all the poisoning cases,
Now it makes difference. Huh?
we don't do gastric lavage, and especially contraindication if it is a corrosive poisoning.
Very good. So this is very important. So we don't do the lavage in all the cases.
Yes, yes.
But in case if you find, as you said, if it is corrosive.
Corrosive poisoning.
Dr. Ankit, that there are certain contraindication of where you are not supposed to do the lavage for the patient.
I was saying in corrosive poisoning,
So in corrosive poisoning, you feel it should not be done because it can lead to
mucosal damage.
because of more damage.
More damage.
Okay, that is one.
Yes.
Anything else?
And in arsenic poisoning,
Arsenic, do you see arsenic these days? I'm yet to see arsenic poisoning. So I would tell you from my side, which I feel, if your patient is comatose, you should never do a right tube insertion and do a lavage. Because the regurgitation followed by aspiration can happen. You can do lavage with them once the airway has been secured. So once they're trachely intubated, the cuff is inflated, you have a protected airway, then you can do a lavage. That is one. Second, which I feel, if your patient is coming late in the presentation. Let's say the patient is being referred from some other hospital, where the patient has already taken poison 2 days back. Now you don't expect anything in a lavage. So
Because it's
most of
already
the
too late.
yeah, it's already late. So once it's already absorbed, what you're saying is basically the tail end manifestation of the poison.
yes.
There's nothing you can stop. So in those kind of cases, it's not going to give you anything. However, just to give a benefit of doubt, because you're inserting rats tube, you may consider for the lavage. But what we want to make the people aware of, if you're doing a lavage, make sure that you're not doing further harm to the patient. Make sure that your patient is not getting aspirated during that process. And it should not be a risk factor for the patient to invite more injury. As you said, in a corrosive poisoning, right? Okay, so that is one part. So I'm very happy that lavage is one thing which you have already explored. Secondly, airway breathing and circulation. So anything specifically, Dr. Dutta, which you want to see in airway breathing and circulation? And then maybe I can ask Aishwarya and Ankur regard to airway breathing and circulation.
Airway breathing and circulation, we will see if the oxygen saturation is maintained, what is the respiratory rate, is there any respiratory distress on the part of the patient, and what's the blood pressure like.
So basically the
lower
vitals,
side,
having a patent airway, making sure the breathing is stabilized,
and
making sure
circulation is adequate.
So breathing, oxygenation, ventilation, airway patency, circulation means your vitals, hemodynamics has been taken care of. So all those kind of things we have to do. Right. Anything which you want to add, Ankur or Aishwarya, in ABC which you feel we must do? What is unique about the poison? Especially like in this case, organophosphate.
Sir, patient goes into tachycardia.
Like in organophosphate poisoning, as Dr. Datta has said, which you feel the patient, you need to settle the airway breathing and circulation. So pertaining to organophosphate poisoning, what you think could be the potential challenges in airway, could be the potential challenges in breathing, or could be the potential challenges in circulation? Maybe you can think. What about you, Aishwarya?
Sir, in order to
So in organophosphate poisoning, what is the common presentation with them? They have bradycardia, they have tachycardia, they have secretions.
yes,
So
sir.
what are the common things that we see?
Yeah, sir. Patient is in
You have to be louder
yes,
because
sir.
you have
Patient
to
is
be-
in tachycardia. More secretions are more. So to overcome these problems, we have to conservatively manage with drugs.
So very good. So what I can draw from your information, that in a patient with organophosphate poisoning, you expect the patient to have cholinergic excess, right? So they come with a common mnemonic, which we have sludge, or you call them as dumbbells. So anything which depicts all this, sludge means salivation, lacrimation, urination, defecation, emesis, and they're commonly bradycardic to present. Because cholinergic excess means muscarinic stimulation, which will cause more bradycardia, right? However, this case was more with tachycardia, which can happen in case if there is direct nicotinic stimulation, right? So that is
Regarding resuscitation is concerned in this patient, because as we have disclosed that we have discovered that this patient is pregnant. So being a pregnant patient and resuscitation in pregnant females, few things we have to consider in this point. Like When we resuscitate or when we check for airway, breathing and circulation, these pregnant females, she is a 37-week pregnant female.
37 weeks.
Yeah. So we consider these patients as a full stomach.
Very nice.
So taking care of airway, because sometimes we found they have some airway edema, full stomach.
Very
So these points has to be considered regarding resuscitation. So we use in modified RSI in these patients.
Very nice.
And while after securing the airway, breathing and circulation and vitals, everything, and the important thing what we have done in this case, the left side uterine displacement was done in this case, just to maintain the uteroplacental circulation and maternal circulation as well.
Very, very aptly raised by Dr. Ankit. So I was expecting Dr. Ankur and Dr. Aishwarya to know these points. As Dr. Datta has highlighted initially, you have to take care of airway, breathing and circulation. But pertaining to organophosphate poisoning, which already Dr. Datta has said, and what Dr. Ankit has added, when you're dealing a pregnant patient who's coming with any other kind of an illness.
Yes.
So when you're taking care of airway, breathing and circulation, why they become different in comparison to the non-pregnant patient, right? So airway, especially the patients who are having a pregnancy, you anticipate airway edema in them. More commonly with pre-eclampsia and eclampsia, but airway edema is common with them, and it's mainly because of the progesterone, which causes water retention. So he said that you have to anticipate difficult airway. Right? The second thing which Dr. Ankita said, that you expect that these patients, they are challenged, yes, so they are full stomach. And because the gravid uterus, which is pressing onto the stomach, is a risk factor for the regurgitation and followed by aspiration. So antacid prophylaxis, aspiration prophylaxis is must in them in case if you're planning intubation. But in case if it is RSI or something where you don't have a time, then obviously you have to take care of all these things in the as a precaution that your patient should be given a cricoid pressure so that they should not get aspirated. Although cricoid pressure is also controversial these days. But the idea is that you should be aware of that my patient is at risk for aspiration, and that is why you should be ready with the suction, and everything has to be done ready, in more specifically dealing with the pregnant patients, so that you can avoid this major morbidity in the form of aspiration and then suction. And third, Dr. Ankit has said, pregnant patient which is beyond 20 weeks of period of gestation, they have to be nurtured in uterine displacement. Because supine hypotension syndrome happened with them. Uteroplacental insufficiency, which can invite more struggle, right? So very nicely summarized by Dr. Ankit and Dr. Datta that you take care of ABC, and then the ABC is different pertaining to a pregnant patient, and then you spoke about the poison per se. So so you did A, B, C in them, and more specifically taking care of the pregnant patients you have taken into account. Then what come the next, Dr. Ankit? What do you think should be the next treatment?
Next, after taking care of all the things, we have to initiate the treatment with usually in such kind of cases, usually we initiate with atropine, injection atropine we use.
So atropine, yes.
Atropine.
So that is important. So organophosphate, and why we suspected organophosphate, because as Dr. Datta has said, the family, they came with the poison bottle, right? So poison bottle was very clearly visible. It was chlorpyrifos, and the patient was coming with a lot of siluria, bronchuria. So she was having features of cholinergic excess, and that is why you started atropine.
Anticholinergic you start.
So let's say that a patient was tachycardic, as Ankur has highlighted. Normally tachycardia is not a common presentation with the organophosphate poisoning. So if your patient is having a tachycardia, Dr. Ankit, and the patient has taken organophosphate poisoning, what could be the possible reasons which I want our audience to understand that every tachycardia doesn't mean the patient is having atropine in excess. Sometimes, why I'm saying this question, I want each one of you to understand, because the endpoint of atropine therapy is tachycardia. Once your heart rate goes up, you stop atropine. But here the patient at the presentation itself is having a tachycardia, right? Even before the atropine therapy has gone into the patient, right? So what could be the possible reasons for a patient in organophosphate poisoning to have tachycardia, where otherwise bradycardia is a common presentation?
Usually in this case, when this organophosphate poisoning presented to us in our ICU, usually they present with bradycardia. If she is presenting with tachycardia, usually it is a late presentation. This is a late presentation of the OP poisoning when they are coming with tachycardia.
Late presentation means, Dr. Ankit?
Already it has been absorbed and it is already in the.
So what I can understand from this late presentation concept, that I don't know whether I should say it as a late presentation or maybe we should say not a typical presentation, which otherwise we expect. Atypical presentation, and there are certain reasons if you allow me to enumerate those cases. One, if the poison is more attached to the nicotinic receptors. So when you have cholinergic excess, you can either have muscarinic features or you can have nicotinic. Generally what you see on the patient, they are a balance between the muscarinic and nicotinic, right? But in some subset of patient, we don't know the reason, but in one subset of patient, you will have more nicotinic symptoms and signs rather than muscarinic. Now this patient was more into this category. Where the patient has direct nicotinic stimulation causes CNS excitation, and they can present with seizure, and they can even present with hypertension, and they can present with a lot of tachycardia. That is one. Secondly, this patient came to us in an intubated state, right? This patient came to us intubated, right? Patient who are having a tracheal tube, the tracheal tube is a direct stimulation, and this itself can cause sympathetic excess, and they can present with, so a patient with a tracheal tube getting stimulated, coughing and bucking on the tube can lead to tachycardia. Third, when the patient is also getting hypoxemic, so when you have a lot of secretions, you become hypoxemic because the patient drowns in their own secretions, and this hypoxia itself causes sympathetic stimulation initially to begin with. You will see that the patient who are hypoxemic, they are fighting and they are breathing fast and they are tachycardic. They use a lot of respiratory muscles, and you find them that they are perspiring. So they basically comes as an initial presentation. So this happens with them. So these are few of the common reasons which must be excluded before you say that this patient is having a tachycardia because of atropine as a reason, right? Now, so the patient, we understand that, on the basis of discussion, that tachycardia can be there because of multitude of reasons. So, if my patient is having a tachycardia, like this case, should I give them atropine or should I not? Now, this question comes. The patient is a case of poison, right? So, what should be your strategy, Dr. Datta? What do you think? How will you decide my patient is tachycardic? Should I give atropine or not? It's a label, identified case of organophosphate.
Actually, what I think that she might have been given atropine right at the point of contact, that is emergency.
Okay, so that could be the reason.
That can be one of the reasons of having tachycardia.
Okay, I agree with you. So let's say the patient has already received some dose. But let's say the patient has not received any dose of it. Let's presume this case. So what you should do? You should give them atropine or not?
Yes, we should.
I think we should give
We should give. So, but once you have a tachycardia, how will you decide atropine therapy?
That depends on how much tachycardia she is having. If she is having a tachycardia of around say 130,
Desirable.
so it's desirable to give atropine. If it's more than 150, then we'll think twice before giving atropine.
I think that is a very valid point which Dr. Datta has said. So tachycardia, having a heart rate of 100 plus is a tachycardia.
Yes.
200 is also tachycardia. 150 is also tachycardia. So we are basically in the spectrum of tachycardia. A patient who is so unstable in terms of tachyarrhythmias, they should not be given atropine because the patient, because the patient is deteriorating because of tachyarrhythmias. Having said so, what we are trying to understand that tachycardia or just the heart rate should not be the goal of care when you are treating the patient with atropine. In other words, if you are having a tachycardia, let's say, but you are having a lot of secretions, siluria, bronchoria,
Yes.
right? And the
Because
patient
these
has
things to be taken care of.
Yes. So if you find that
Some
rest
amount of tachycardia is desirable because other things, other secretions,
Yeah.
patient should not drown their own secretions.
So the idea, as you said, Dr. Ankit, that we should allow some degree of tachycardia,
Yes.
and we should take them with a pinch of salt. That because this tachycardia because of direct nicotinic stimulation, but at all the point of a time, idea is to see all the constellation of signs and symptoms and not just tachycardia.
Yes.
And as Dr. Datta has said, very wisely said, when you have a tachycardia, assess the degree and the severity of tachyarrhythmias. Not every tachycardia means a contraindication for atropine therapy. Versus a tachyarrhythmia of heart rate of 180, 150 which eventually needs more stabilization rather than doing anything else in that given case. Anything else apart from, so what should be the goal point, Dr. Datta, which you feel my patient is a poison, take an organophosphate, I'm giving drop-in therapy. How should I decide what should be the target endpoints and which we feel should be the part of the standard of care in today's medicine?
We can see the dilatation of the pupils.
So yes, so pupil dilatation.
And we stop giving atropine once the heart rate reaches around 150 or 160, and the pupils, all the pupils are dilated.
So as Dr. Datta has said that either the patient is going tachycardic, then you will stop, or the patient is having a, the pupils they are getting dilated. But in this case, there was already tachycardia. So in that case, tachycardia we cannot take into the consideration. Pupils, yes, one you can take them. Let's say somebody has already received some therapy in the eye, or the patient is having some pupillary defect. Then what should be the target of therapy?
Then we should think we should see and we should look how's the secretions in the
Yes,
mouth.
this is what I want to
Ideally,
discuss.
after atropinization, it should be cotton dry mouth should be there.
So two important things Dr. Ankit has said. You have to look for the signs of atropinization.
Yes.
Now this is what we wanted to highlight. Atropinization doesn't mean only heart rate. Atropinization means change in the heart rate, change in the secretions, change in the blood pressure.
Yes.
So I think this is what we are looking for. So don't take anything in isolation, because tachycardia could be because of multitude of things.
Exactly.
Meiosis could be because of multiple things.
Maybe drug.
Let's say maybe the drug abuse, maybe the patient is on opioid, right? So there could be a lot of things. Or maybe the patient is on epinephrine therapy, which can cause pupillary dilatation.
Yes.
We start a lot of patients on ADR infusion.
Correct.
So multiple things can happen. So very rightly said. And the second thing you said, there has to be a bottom dry mouth. So recent evidence they suggest that now the patient should be tried, and it should be titrated to the level of when you have this drying of the secretion, which I'm having. That's why I'm having a water, because I'm on antihistaminics. So I'm having a hot and dry mouth. I'm ready for extubation. Okay, so once we achieve this thing, what should be the next plan, Dr. Ankit? Okay, I started patient on atropine. In the evening, the patient looks hot and dry.
Yes.
What should be my extubation strategy in that?
Very importantly, very rightly said, if the patient is showing the signs of atropinization, and if you are seeing it in the same day of evening only, we may feel the patient is looking symptomatically okay and his vitals are also okay, but the patient is not fit for extubation very soon, because
Very
same
soon.
day only she got intubated, because there is a entity we call it as a intermediate syndrome, which we used to deal. So usually after tokenization also we should wait for at least for 3 to 4 days, because intermediate
How
syndrome,
earliest, if I can ask you, barring this case, how earliest you have extubated a patient with organophosphate?
earliest
How earliest in your experience?
within a day of 2 days of.
You have extubated a patient in 2 days? Organophosphate. What
Yes.
about you, Dr. Datta? How
But that is
earliest?
not right.
No, we are not discussing right and wrong. We will go back to the right and wrong maybe in the later part of the discussion. But how earliest you have extubated a patient, successfully extubated? Let me
around
quickly ask a question.
72 hours.
3 days.
Yeah.
Actually, the point the reason why I asked this question, if your patient is coming as an organophosphate and you're giving antidote in the form of petropin, and which is the right antidote, you will find that within few hours the patient looks
Stable.
comfortable, stable, breathing nicely, and they are much more better. I'm not saying all the cases, but majority of them. Now this is because you are using antidote in the form of petropin therapy. It is not because the patient physiology has changed. It is because you are giving an antidote in the form of petropin. This one specific thing about the organophosphate. Organophosphate compounds, they are extremely lipophilic. When I say lipophilic, it means they have a strong affinity for the fat deposits.
Fat deposits.
So when the patient takes any organophosphate poison, right? This goes, it gets absorbed, and eventually it goes into the tissue deposits, which means it may not be there in the stomach, but the stores may even be there in the fats, adipose tissues. Now, although patient is not taking any more poison, but this tissue deposits, the storehouse and the fats, they will keep on eluding into the circulation slowly and slowly. And that is why the patient will continue to behave as if that the patient is still under the effect of toxins. And nobody knows how many stores they have. So by and large, if you see the evidence, they say that the patient with the organophosphate poisoning should rarely be extubated in the first place. Now when I'm saying it is with the context that the patient has taken the poison, I'm not talking about where the patient has not taken the poison or taken a very small quantity of dose. We're not talking about those kind of cases. Is it okay? So idea is that if the patient has taken a clinically significant dose of poison, it takes at least 7 to 10 days before it's going to remove, before it's going to be completely removed from your body, because 4 to 5 T-halves of any typical organophosphate takes around a week. Right?
Yes.
And that is why we should not prematurely extubate in them. They may look good. In fact, that is the reason why they should still be continued on atropine therapy.
Exactly.
So you should not stop atropine before 7 days. You should not, by and large, you should not consider for extubation before 7 days. It's a 7 days rule which we follow there. Because whatever is happening is because of the atropine you are giving. In fact, there's another way of seeing this thing. Let's say you're giving atropine and there's no change in the heart rate. It means that the patient is still heavily dosed off with the toxins. So if you find that the patient is stable on atropine, it means the patient is significantly having a dose of toxins. Because with atropine, the patient should be showing signs of tachycardia and restlessness and everything. But if patient looks stable on atropine, it means the antidote is working, for which there is actually a poison inside the body. Do you understand? Atropine should make the patient tachycardia and unstable. Atropine is not easy to handle. But if the patient is requiring atropine and on the atropine the patient is stable, it simply means there is enough amount of poison in the circulation which is making your atropine to act stable.
Dr. Manish, I want to add just one point. This also depends on the amount of
Yes,
toxin which
very
the
much.
patient has.
I agree with you. I agree with you.
If it's a small quantity,
No,
so
I agree.
the effect will go away faster.
No, you are very much right, Dr. Datta. In fact, that's why the decision of extubation should be on case-to-case basis. I completely agree with you. If the patient has taken a clinically significant dose, which means to the extent that the patient has got intubated. See, how do I decide my patient is clinically significantly has taken the toxins? That I decide on the basis of my initial presentation. If the patient has thrown a seizure, if the patient has been sick enough that the patient warranted intubation, I presume that the patient has taken a clinically significant dose. Versus a patient who is coming, who has taken, or I would say who has tasted the poison and coming to you in an asymptomatic state. They don't need intubation.
Yes.
But the patient who has been sick enough that the patient got intubated outside some hospital,
Requiring isolation.
I'm presuming, requiring ICU admission, I'm presuming that the patient must have taken a clinically significant dose. In that situation, I think we should be restrictive in our approach. There are some indications in critical care medicine where you are not supposed to give them daily SBT trial or the extubation trial, and one of them is your poison. But having said so, I completely agree with you, Dr. Datta, that it has to be neutralized. Which means just because we have a 7-day calendar which has been given as a reference, doesn't mean we are not going to assess the patient on day-to-day basis. That assessment anyhow has to be done. So I agree with you. So Ankur and Aishwarya, now I want to know from you. We did the same thing which Dr. Ankit and Dr. Datta has said. We intubated the patient, airway breathing circulation optimized. As Dr. Ankit said, aspiration prophylaxis was given. Left uterine displacement was given to the patient. Circulation stability was achieved. Now the patient has been extubated, right? Obviously, after 4 to 5 days of mechanical ventilation, the patient got extubated because we realized. So, what do you think you have learned from this exercise as a case of organophosphate poisoning? which you are going to use in the next organophosphate poisoning? The learnings which I want to know from you and maybe one from you.
So first of all, we have to manage the airway, breathing and circulation.
Okay?
If the secretions is more, we have to manage drugs, and the extubation should be as low as possible after the proper sign of atropinization is visible. Then we should extubate the patient.
So let's say, again, I have to understand. Let's say I did the patient, atropine therapy has been started. By the evening, there are signs of atropinizations. Should I extubate?
No,
So, can you help us in understanding that? When will you plan extubation in them?
Sir, after the proper effect of the poison is being off.
So how will you understand?
As you said,
Yes.
so the protocol is ideally you should wait for about 6 to 7 days
6 to 7 days.
before you plan extubation.
So there are various ways, why I'm telling you, Ankur, this is important because Ankur and Aishwarya, they both are in trainees phase. This is one poisoning which can be asked in your exams. So, one, as I said, that this poison is lipophilic. It's going to stay in your circulation. What you see as a sign of atropinization is because of the atropine therapy, not because of the change or the normal physiology. So you should consider extubation when you're really sure that the poison has been taken off from the body. It has been taken off from the tissue stores, which typically takes 7 days. Or when you see the patient with organophosphate poisoning, they directly affect which enzyme in the body? Aishwarya.
Acetylcholine.
So they affect anticholinesterase. They are clumped under the category of anticholinesterase. So they affect cholinesterase. And this cholinesterase levels you can measure in the plasma. More specifically, RBC cholinesterase, which are true cholinesterase. There is another cholinesterase which is known as pseudocholinesterase, which is there in the plasma. RBC cholinesterase levels you can measure, and they are available as a test, and this test is known as DBQN number. DBQN number. So DIBUCAI. And DBQN number is basically just to rate the level of cholinesterases which you have in the plasma, right? And it's available as a test, and on the basis of this number you can decide whether the patient has a significant poison in the body or not. Ibuprofen, and ibuprofen is the local anesthetic, by the way. Ibuprofen is the local anesthetic which used to be used in the past. It's available as a test. Unfortunately, RBC cholinesterase is not available. We have pseudocholinesterase level, which can be used as a surrogate but not so recommended. But that gives you a fair idea that to what degree did we had the anticholinesterase level in this case? We measured. We did. So, would you like to add some points, Aishwarya, and then I will ask Dr. Ankit and Dr. Datta to close. What is your learning which you are going to use in next time in your case? He said he would like to wait for the extubation because we have seen that the poison is still there in the body, right? On the basis of the evidence, the literature. So he will be slow in weaning off them from the ventilation. This is what you said. What about you?
Sir, as pregnant ladies are considered full stomach. So, sir, there will be a difficult intubation.
So difficult
There are
intubation.
chances of aspiration.
What will you see in that case? Aishwarya said, I will see to it. But what will you do? You are right, they are having a difficult airway, but what will you do in that case? Identification of problem is okay, but what will you do as an intervention? Will you do anything?
You will prepare a difficult airway card ready.
So keep a difficult airway card, ask for a senior to have an assistance, and anticipate that these problems are likely to happen. So you should be ready with your appropriate interventions. Huh? So, Dr. Datta, would you like to have any closure remarks? Anything which you have learned from this case?
Apart from atropine, can you use something else like ralidoxine?
So, oxymes, they have been recommended, especially when the patient is coming early as a poison intake. within the first 48 hours. Various studies are there. The largest study, I think it's done from the PGI Chandigarh, North India. They endorse that it should be given, even if the patient is having a late presentation.
Is there any contraindication in pregnant patients with parallel?
I see there are a lot of things. Even atropine has a tendency to cross the placenta. Now the point here is that I don't think there is anything more relevant than the patient survival.
Yeah,
The opsines safety and efficacy, I'm not very sure in the pregnant patients, because again this was a unique case for us. But idea is very simple. Opsines may or may not give you the benefit. That is why we have refrained from using it. Secondly, the patient came late to us. Atropine has relatively more inert issues, and although it crosses placental barrier, but still it has minimum harm possible to the fetus, and that's why we chose it. Opsines, they are recommended by one body, but whether they improve the survival, we are not very sure. What about you, Dr. Ankit? Anything which you would like to?
Thank you. So after taking care of all the things and successfully we have so after taking care of all the things, precautions, now the patient is in front of you. She is extubated after 5 days of stay in our ICU.
We can have a look over the patient. Huh?
Yeah.
And she has been extubated for now, I think, almost 3 days.
कैसे हैं आप? ठीक हैं? ये वीडियो में हम बात करना चाह रहे हैं. कैसा लग रहा है? ठीक लग रहा है? हाँ? कोई तकलीफ? वो भूख लगी है? वो तो ठीक हो जाएगा. भूख तो अभी खिलाएंगे, सब चला जाएगा. वैसे कोई तकलीफ? दोनों हाथ ऊपर उठाइए. ठीक है. जीभ दिखाइए. ठीक है. कोई दर्द? पेट में दर्द? ठीक है. So as you said, anything else, Dr. Ankit?
So this is the status of the patient after this is the 3rd day of extubation. So we have extubated her, and the close monitoring was there just to observe is there any second hit or anything like that. So now the patient is ready to discharge from the ICU, and
This is very important, yes, what Dr. Ankit is saying. Even if you're extubating a case of organophosphate, what Dr. Ankit is saying, you should always be aware about this is one category which will require frequently re-intubation. So second hit, which Dr. Ankit is saying, that is pertaining to that they again become cholinergic excess. They again develop those signs and symptoms of having excessive cholinergic activity, and they may require a re-intubation. This is one entity where the re-intubation incidence is high, especially if the intubation attempt has been made early, right? Like in this case, you extubated early. So in that cases, you should always have this thing in the back of your mind that they may require re-intubation. So with this, I would like to bring closure to this case. My throat is not keeping well, so obviously I have to allow me to have sips in between. This is not a very good practice that you should drink inside the ICU. But I think everything is fair in love, war, sepsis, and when you have a bad throat. Thank you. Hare Krishna.